And now Dr. McKhann will be our next speaker. Dr. McKhann is professor of neurological surgery at the Neurological Institute of New York at Columbia University Medical Center. He received his undergraduate degree from Duke University and his medical degree from Yale University. He specializes in microneurosurgery, deep brain stimulation, and gamma knife radiosurgery, as well as intraoperative awake brain mapping. Dr. McKhann. The title of his talk is The Changing Face of Epilepsy Surgery, New Approaches to Old Problems.
Thank you very much, Dr. Pedley. As Dr. Ford said, it is a true privilege and an honor to be here. And I hope everyone in the room realizes what an incredible service to the Southern India community that the Srinivasan family has done by endowing this annual lectureship. It's really, for us, been a remarkable opportunity to interact, make new friends, learn from each other. And so really, deep thank you to the Srinivasan family for that, and also to Professor Gangadhar for his incredible hospitality up at NIMHANS, which is a world-class facility with amazing people there dedicating their lives to care for the people of India. And also, obviously, to Professor Krishnamurthy of NeuroKrish here in Chennai, another gem of a resource that we all wish we had people like you have here in the US. So thank you very, very much. I'm going to switch to a different topic now, and because we're talking about neurotechnology, I'm going to talk about epilepsy surgery, but particularly how neurotechnology has approached epilepsy surgery and how it's changed it really in the last 5 years dramatically in the US, and it's spreading more around the world. And in epilepsy, first off, for everyone in the room who's not an epilepsy person, epilepsy surgery is only a consideration if somebody is continuing to have seizures despite being on adequate medication. So if a patient has seizures and they're controlled on medication, there's no reason to consider surgery. These are for patients who, despite taking medications, continue to have seizures, and that's the base group of patients that we're dealing with. Now, in our system in the US, about 1% to 2% of people will develop epilepsy, and of the people who have epilepsy, over half of those will be refractory to medication at some point, and many of those, up to 20 to 30%, are potentially surgical candidates. But as I'll talk about, there are a lot of things that prevent people from having surgery, and I think some of these neurotechnologies may be changing that dynamic. So my only disclosure is that I'm an investigator in a trial for laser ablation, which is something I'll talk about. It's always important, because we run out of time at the end, to acknowledge our colleagues up front. And I work with outstanding surgeons at my institution, incredible epilepsy neurologists, and also thank you to many friends who have helped provide information and ideas for aspects of this talk. So as an introduction, there's very few things in surgery that have ever been really studied within a randomized controlled trial. Epilepsy surgery is one of them. One of our most common surgery is for what's called mesial temporal lobe epilepsy, and what this graph on the right shows is that, in fact, surgery is the upper line and medical treatment is the bottom line, and it's a survival curve. So surgical patients basically are freed of their epilepsy about 60 to 65% of the time, whereas medical patients who have epilepsy and are medically refractory almost never respond to more medications. But despite that, when people tried to run an early surgery trial, let's get people to do surgery earlier because we know that more and more medications aren't going to work, they weren't even able to get the patients to come into the trial because there's so many patients who are resistant to the concept of surgery. But even in that limited trial that was closed after a small number of patients, 73% of patients became seizure-free with surgery, and there were no patients free with medical therapy. So if we had to summarize the state of temporal lobe epilepsy surgery, particularly for what's called mesial temporal lobe, it's very, very effective but underutilized. In contrast to mesial temporal lobe epilepsy surgery that we can see here is at about 60 to 80% seizure freedom, and if somebody has a brain tumor or a benign vascular lesion, those patients also do very well with surgery. But when we get to other parts of the brain, particularly when somebody has a normal MRI scan, They've got seizures coming from one part of the brain, but you can't see on an MRI where it's coming from. Then we start getting much poorer results. And in fact, over time, we're down below 40% seizure freedom after epilepsy surgery. So outside of the temporal lobe, in what's called extratemporal epilepsy surgery, it's very invasive, as I'll talk about. It requires bigger surgeries that have greater risks, and it's not nearly as effective as temporal lobe epilepsy surgery. So what our job is as teams of epilepsy people, and just like in the movement disorder world, where it's been my great pleasure to work with Dr. Ford for 20 years, epilepsy is the same way. It's a team. If you don't have a team of really good people, you can't tackle these problems. And our goal as a team is, if somebody is not responsive to medications, to try to do what we can surgically to remove the area the seizures are coming from in the brain, provided we can do it safely. So what patients want to know is, A, are you going to stop my seizures? B, what's the risk going to be? And C, can you find a way to do it less invasively? Because surgery, we all get it. It's a scary thing. There's risk to it. Nobody wants to have their head opened if they don't have to. And in fact, I say to patients all the time, they say, "Doctor, I'm so nervous about my brain surgery." I said, "That makes you normal." I said, "If you're not scared of brain surgery, we've got a real problem." And so it's a normal reaction. So one of the big things that's going on is to make surgery less invasive and safer for both temporal lobe and extratemporal lobe epilepsy. And in fact, surgeons spent the last several decades making an operation less invasive for temporal lobe epilepsy. So this is actually a cross-section of the brain. And what we can see here, the ears are on the sides of the picture, the nose is coming out of the screen. And most temporal lobe epilepsy comes from this little area here, number 1 and number 2. But yet for most temporal lobe epilepsy surgery, traditionally, we've been removing all of the temporal lobe here for a pathology that's really just here. So surgeons, thinking that they're quite creative individuals, found every possible way to get to the inside, coming from the side, coming from more on top, coming from underneath the temporal lobe, every way we can get there to make an operation more selective. But at the end of the day, for patients, even though it is a smaller operation, and even though it works just as well as a bigger operation for most adult patients, patients still say, well, it's a surgery. They don't look at the nuance like we do as surgeons and say, oh, that's a better surgery. They say it's still a surgery. And so for them, it's the same barrier to overcome. So a lot of the work in the last decade has been, okay, well, how do we make surgery really less invasive? So the first thing that was looked at, really starting predominantly with the French in Marseille with Jean Rougy and other groups around the world, was to look at radiation. What if we take radiosurgery? So Gamma Knife is focusing 200 beams of radiation at the area you want in the brain, almost like, think of it like a sphere, like a bunch of kids with magnifying glasses. You have one magnifying glass, you don't have that much energy. You put 3 or 4 together, and all of a sudden you've got a brush fire. So with radiation, you have 200 beams, they're aimed down at a central target that gets all that radiation. So on this scheme here, the target here area is on the inside here, and then the radiation dose is in the yellow, so you can very well construct a radiation dose to the same area that we would remove surgically. And so the initial trial looking at this was very encouraging, and it showed that over time, radiation seemed to be just as good as surgery. So it led to a randomized trial that was done called the ROSE trial, radiosurgery or open surgery for epilepsy. There were 13 US sites and the All India Institute in New Delhi that enrolled patients. But again, like a lot of surgical trials, it failed. Because if you're a patient and somebody says, we want you in a trial and we're going to randomize you to open surgery versus to getting radiation in your brain, there's such different treatments that most people didn't want to take that chance. They knew what they wanted. They either wanted radiation to not have open surgery or they wanted open surgery. But within the amount of patients they were able to enroll, actually, open surgery did a lot better. So in open surgery, they had almost 80% of patients that were seizure-free versus just over a half with radiation. And the radiation patients had a lot of side effects from edema from the radiation, swelling in the brain, needing to stay on steroid medications because of that. So radiosurgery probably has a role for patients who absolutely don't want surgery of any kind or are too high risk for anesthesia, but it's not going to take over surgery or be a replacement for it. So the next thing that's come along that really has been a game changer is what's called stereotactic laser ablation. And Dr. Ford showed how stereotactic surgery is done, and I'll go into it a little more here. But essentially what it's doing is it's putting a stereotactic laser fiber from the back of the brain down the long axis into the inside of the temporal lobe to treat that area in an MRI scanner with laser energy at the time. And so this is the actual laser machine. This is the laser cooling catheter with the red is the laser fiber on. Obviously, we don't do that at home with our kids. And what you do is you implant a fiber and then you treat in the MRI scanner. So what we do ahead of time, this is automated planning software that's being developed by the University College Group in London that actually allows a computer to now plan the best trajectory in an individual brain. We plan that trajectory and then we do the procedure. And here's a schematic movie of how the procedure is actually done. We put a frame on the head, and then once that frame is on the head, I'll skip ahead a little bit here. We then go ahead and we pick out a trajectory. We make a drill hole. We put a little screw into the head through a 3mm incision. We place the laser cannula down, right down into the target where we want it to go. And then the patient goes into the MRI scanner. We take pictures of exactly where the laser fiber is. We make sure it's where we want it to be. The laser itself is outside of the magnet of the MRI bore. And then we can look, and in semi-real time, every few seconds of update, we can watch the lesion being made in the area that we're lesioning with the laser itself. And so again, this is again a schematic showing that the laser fiber is in the tip within the cannula. You treat that area, you back the laser fiber up, you treat the next area, and so you can do that with the geometry of your target depending on how well it fits the anatomy of what you're doing. And with an actual treatment, this is what it looks like. It's sped up here, but you treat one area, you back the laser fiber up and treat the next area, and so it's almost like you're stacking snowballs one on another to make a lesion in the area you want to. So it allows us to watch the temperature in the MRI scanner, which is a real advance in MR imaging, to be able to do something through a 3mm hole in the skull rather than having to open the head to get to that area to treat it. And again, this is just summarizing all of the individual steps of putting the laser fiber in, making the lesion, and then doing an MRI scan at the same time to see what you've done. And getting the right target actually is important. This is work that's been done by Professor Sharon's group. His colleague Chen Wu has gotten 11 centers around the US, of which we were one of them contributing our data. And what it turns out is that if you put a lesion exactly where you want it in this green area, patients do much better than if you're slightly off in this red area. So you've got to get the laser lesion in exactly the place that we would normally want the surgery to be. So what happens with this is that if you compare laser to open surgery, because we're doing a very finite lesion in the brain, and because laser technology is not that advanced in terms of how you sculpt that lesion, it's not surprising that it's not as good as open surgery. So if we do an open surgery, as some of those earlier trials and things showed, we've got a somewhere 70 to 90% chance, depending on the patient's individual characteristics, of stopping their mesial temporal epilepsy. Whereas with a laser, it's only about 50 to 60%. So very clearly, it's not as effective as open surgery. But it's done through a 3mm hole in the skull. A patient goes home the next day, sometimes the same day. There's no major recovery from brain surgery. So what I've found in my practice, and many other people who do the same sorts of things, is that now patients are coming and they're saying, I want this procedure. And if it doesn't work, then you can try your open surgery, knowing that there's a very good chance, better than 50%, closer to 60%, that it will stop their seizures. So there's a good chance they may never need to go on and have that open surgery. So that's been a real shift. And in fact, we've gone in the last 5 years for doing all open surgery to now 80% of our patients or more who have mesial temporal epilepsy get a laser procedure, and a lot of them therefore don't go on to open surgery. So I'm going to move now from mesial temporal lobe to extratemporal epilepsy. Extratemporal epilepsy is important because it's interesting, and in talking to colleagues here at McKhann and other places, you all obviously have a population advantage on us in the US, and so in that, there is actually a lot of mesial temporal epilepsy that's being seen at places like McKhann. In the US and Germany, England, it's going away. And it's not quite clear. It's not just because there's so many doctors, although we do have too many doctors in the US, but it's actually the demographics are changing. Whether it's because of seizures being treated better in young children or whether there's a viral etiology, we don't know, but it's going away. And what we're seeing is more difficult epilepsy cases, people who don't have tumors, don't have infections, don't have vascular lesions. You say somebody's got epilepsy, you think it's coming from the frontal lobe, and you do the MRI scan, and it's stone cold normal. 1.5 Tesla, 3 Tesla, 7 Tesla, throw in all the Teslas you want, rechargeable batteries, it's normal. So those patients are very, very difficult. So for instance, if we take the example of a frontal lobe epilepsy patient, so these are now over a quarter, 30, even up to 40% of what we're seeing. So frontal lobe epilepsy oftentimes comes on as childhood. We all suspect that there's a very subtle developmental abnormality somewhere in the brain, and we just haven't gotten good enough with MRI to find it yet. But if you can't see it, you don't know where to go. And the frontal lobes are very, very interconnected from one side to the other. And so what happens is seizures can spread incredibly quickly from one frontal lobe, front to back, side to side. So the frontal lobes are half the brain. And so you can sit there, and while we can say, oh, it's great, we think it's in a frontal lobe, that means we've got it nailed down to one half of one side of the brain, provided that we're not wrong and it's not coming from the other side and spreading super quickly from one to the other. So in those sorts of situations, we're really left with having to figure out where to go find the seizures. And so again, these are all the white matter connections in the brain, in the frontal lobes. There are multiple pathways that allow seizures to spread very quickly. And not surprisingly, over time, this is over the last several decades, frontal lobe epilepsy surgery, we haven't done very well. Like I said, around 40% seizure freedom. And B, we have to do a lot of surgery to get a 40% positive outcome that over time probably isn't even that good. This is actually from the Cleveland Clinic group. You see temporal lobe epilepsy versus extratemporal epilepsy were not nearly as good. So traditionally what we've done, if we think seizures, for instance, are coming from one of the frontal lobes and maybe the temporal lobe, we've done a large operation where we open up the head and we put a whole panel of electrodes on the surface of the brain. So on the left of the picture up here that you're looking at. Every one of these little dots in white is an electrode contact. They're separated by a centimeter. So we open up the brain, we put these on the brain, and then we put the bone back in, close everything up, and we monitor the patient for a while until we record their seizures, find out where they're coming from, figure out if we can safely remove that area, and then go back and do another surgery. So it's to just get the information, we have to do a really big operation that as I have no qualm saying, is my least favorite operation that I do. And so what's changed is that we're doing a lot more of what's called stereo EEG. We're on the right here, and this is a patient you can see with a scar who actually had failed a big operation at another institution in the past and came back because their seizures were still there. And every one of these little white letters is a cap to an electrode. And just like we put that laser fiber in with computer guidance, we're putting individual electrodes in through the skull, through tiny little holes to record the brain activity rather than opening up the whole head and putting a big plate of electrodes on the surface. So the principles of this are, first off, as a surgeon, we're only as good as the neurologists that we work with. And so the most important thing is, can we figure out as a team where we think the seizures are coming from? And again, not just frontal lobe. And I'm the son of a neurologist, so I love this part of epilepsy neurology because there's a resurgence of behavioral clinical neurology. The MRI does not give you the answer. The patient gives you the answer. So in fact, when you see people who are really experts in this, which I will freely say I think that the Europeans are the best in the world, particularly some of the French and Italians, they dissect tiny little behavioral features at the start of a seizure and say, oh, you see how the mouth moves that way? It moves upwards and not downwards. That means it's probably the front bottom part of the frontal lobe, not the back outside part of the frontal lobe. And it's putting together classical behavioral neurology of seizures together with EEG recordings and coming up with what's the hypothesis for where the seizures are coming from. And then putting all that together and saying that tells us where we want to put these little tiny electrodes into the head. And so what's interesting is that these techniques are not new. So in fact, as you can see, these are not new photographs. So on the left is Wilder Penfield in Montreal decades and decades ago putting a big subdural grid in. And this is actually Banco and Talleyrand in France putting in stereo EEG, little electrodes decades ago. So the technique's been around, but nobody bought in until really the last 5 to 10 years outside of a select group of Europeans. So what happened? So what happened is that technology happened. Technology and information happened. So first off, there's the internet. So everybody knows what everybody else is doing. Second off, technology is advancing and advancing really fast. And so this is a cast of a real human brain showing all the blood vessels on the brain. So as a surgeon, if Dr. Sharon or I are looking at trying to put, say, 12 electrodes into the frontal lobe area of this brain in this area right here, what everybody else sees here is brain. What we see is blood vessels. Because what we see is how do we not hit the blood vessels? So if we're going to be putting little electrodes in, we have to know exactly where we're putting them and be really certain of that. And what's changed is now we've got really good ways to look at the brain and image the brain better than we've ever been able to do it before. So we can see those tiny little blood vessels before an operation. And also we've got robots to help us put in electrodes to make sure that when we plan a trajectory on a computer and then go into the operating room that we put the electrode exactly where we want it to go. And so there's really been an imaging and robotics tipping point where technology has made it so much easier and safer that something that before a lot of surgeons looked at and said, geez, I can't believe those Italians and French are doing this, to now everybody's changing over. The world in the epilepsy world in the last 5 years has gone from almost all subdural electrodes to shifting to this approach because we're not opening up the head. Because if you say to a patient, I can do a smaller surgery where I make a bunch of little holes in the head and put screws in the skull and put electrodes in, but I don't actually have to open up your head, expose your brain to the outside world, do a big surgery. Because remember, this is a diagnostic surgery. We're just trying to find where the seizures are coming from to figure out if we can really help somebody. So what we do, we map out the plan for where we want all the electrodes, and then we merge it to all the patient's specific brain imaging. We decide exactly where we want the electrodes to go, and then we build it onto a computer robotic model. And then when we go into the operating room, I had a video here. Let's see. I think it's one slide out. So this is a planning slide here now too. The same group I showed before out of London has developed software now where a computer will plan your trajectories for you. As a surgeon, we can say, I want an electrode to go into the brain right here and to end exactly at what spot on the inside, and a computer will tell me what's the best, safest trajectory to go there. This is what we do as surgeons. Dr. Sharon and I have suffered for hours before every surgery doing this, and now a computer can do it in 15 minutes, and probably in 5 years a computer will do it in a minute. Tells you exactly where you want to put the electrodes, and then we go in the operating room, and fortunately the computer can't do this part yet, so we still have jobs. And so what we do is this is actually the robot driving to the exact trajectory where we want to put an electrode in. And what we do is we just mark that spot, and this is sped up slightly, but once we mark that spot, we basically make a tiny little incision in the scalp, and then we stop any scalp bleeding that's here. We then drill a very small hole in the skull with about a 2mm drill bit, and then through that hole, we're going to put a screw, an anchor bolt, into the skull, just like we did for the laser procedure. And so here comes an anchor bolt being screwed into the skull right here. And then once that anchor bolt is in, we pass a probe down exactly where the electrode is going to go. And actually, if there's a blood vessel or a problem, if you're very gentle, you can actually feel it so you don't cause a problem. And then at that point, once we know the trajectory is good, we go ahead and put in the actual electrode. So for each electrode, once we have everything planned, it only takes about about 3 minutes to put in the electrode, then to make sure everything's good, about 5. So if we put in 12 electrodes, 15 electrodes, it's an hour and a half, instead of a 6-hour operation to put in that big array of electrodes and test it and everything. There's a lot of computer time, a lot of planning time, so it's still many hours of anesthesia, but it's a much less invasive operative procedure. And so what we end up afterwards is an image where we can see where all those veins and arteries are. We can see where we plan to put the electrode in. So this green electrode here is the plan. The yellow is the actual position of the anchor bolt. So exactly where we planned it to go. So what this has done is allowed us to get 3-dimensional coverage in the brain, much better than 2-dimensional coverage that we got just by putting things on the surface. If we find when a patient's in the hospital, when we record their seizures, even though we've done everything we can to pick the right spot, we're not always right. So if we need to add more electrodes, we just go back to the operating room and add more electrodes. If you've put in a big array of electrodes, without going into the details, surgically it's very challenging to add more to it. So you can augment electrodes, you can check both sides of the brain if you need to make sure seizures are not spreading really quickly from one side to the other. And again, less operative time, less pain, less morbidity for the patient. So it changes the operation dramatically and gives us a better chance of finding where the seizures are coming from at less risk to the patient. And because of this, many more patients are now willing to undergo a surgery to see whether, in fact, they have a good chance of stopping their seizures than there were before. It is different for us as surgeons and for our neurology colleagues, because instead of having electrodes on the surface of the brain, now you'll have an electrode where one part of it is going through one part of the brain, in this case the primary sensory area. Then the same electrode will have contacts going through the primary motor area, and the tip of that electrode will be in an area called the supplementary motor area. So these are very different areas of the brain in terms of what they do, and you'll have contacts of the same electrode sampling very different areas. So it takes a new learning curve in terms of that and learning how to interpret everything. So the disadvantage is that there's a learning curve, that we can't map the brain as well. There's some other things in terms of that a team has to learn, but it's interesting. In our institution, the surgeons really generated bringing this in, and now our neurologists have totally bought in. They think it's a much better way for patients, and our team is totally in agreement that it's the way to be going. And so what's happened, without going into all the details, almost every situation where we previously were placing subdural electrodes, we're now doing stereo EEG on the left side here. So if we look at, these are our first 50 patients from back in 2014, 2015. We placed 536 electrodes, and in those initial patients, out of 50 patients, we were able to find an answer, whether or not that patient was a definitive surgical candidate in 47 out of 50, and 35 out of those 50, we were able to then go on and do a definitive procedure. So in fact, and despite now we're at over 125 patients, over 1,300 electrodes placed, we haven't had a single major complication. There's no way you could put in 125 grids and not have a major complication. It's just what happens when you do bigger operations. Bigger operations cause bigger complications. So it is changing the field of what we do. So I'm going to show you one example of a case that shows how we combine these technologies, laser ablation and stereo EEG. So this is a 24-year-old young man who has a particular type of brain developmental abnormality called a periventricular heterotopia, which I'll show you in a second on an MRI. And he has it on both sides of the brain. And even though it's on both sides of the brain, it seemed like all the seizures were coming from the right side of the brain. But when somebody has this particular abnormality, so if you look on the MRI on the left here, what you see in the back is there's this extra gray tissue just outside the black, inside the white here. So that is actually gray matter of the brain that should be at the surface, but when the brain develops from the inside to the out in utero, these cells got stuck and they didn't migrate. And they're here on this side, and they're also here. And what happens when patients have these abnormalities, sometimes the abnormality seizes, And sometimes the abnormal brain, because those cells didn't develop normally, seizes. So we don't know, are the seizures coming definitively from this side, the area over it, or this side, or the area over it. We thought it was this side because MRIs are backwards, left MRI is right. So we did an implant on both sides of the brain, more electrodes with stereo EEG on the right side, less electrodes on the left side. And what we found is that the seizures were coming from the right side, but from two different areas. One was the hippocampus, the same area that I showed with the laser ablation before, and the other was actually from the periventricular heterotopia. So what we were able to do in this case is we were able to plan out where we actually put two laser fibers in. We put one from the back into the hippocampus, just like on that video I showed before, and we put another one into the heterotopia, and we treated both areas through two little twist drill holes in the back, so we were able to stop the patient's seizures without ever having to open up his brain, which would have been unheard of 5 years ago, because laser ablation didn't exist even if we had done stereo EEG. And in this back part of the brain where this heterotopia is, there's almost no way as a surgeon, no matter how good you are, to get there without causing problems. So in fact, not only was this less invasive, it saved complications that almost certainly would have happened with open surgery. So again, changing the dynamic of what we do. So in the last couple minutes, I'm just going to quickly show a couple of other things that are new that have come along in terms of technology. This is a new technology called responsive neurostimulation. This is for patients in general who are not candidates to try to cure their seizures, either because the surgery would be too dangerous, because of where the seizures are coming from, it's an area that's too important functionally, or sometimes we can't be certain exactly where the seizures are coming from, but we think they're probably from a certain area, but we're not sure, so we don't want to do an open surgery. So this, Dr. Ford shows us, this is a battery device that's inside the skull. It records the patient's seizures, and when it sees a seizure coming, it stimulates the area where we think the seizure is coming from, almost like a pacemaker, to try to knock it out. And what happened in the early studies is that we found that if you put multiple electrodes close to where you think the seizures are coming from, in fact, then this helps. But it's not usually curative. So in fact, if you look at patients with various forms of epilepsy, the median seizure reduction is somewhere 70 to 80% over many years. The goal in epilepsy, for us as epilepsy teams, is to cure seizures, because that's what makes the biggest difference in quality of life, but sometimes we can't. And if we can't, sometimes dropping somebody's seizures by 70 to 80% can still make a big difference. But it's very expensive technology. Whether or not it's going to be cost effective over time still needs to be sorted out. Interestingly, almost 20% of patients had 1 year of seizure freedom over the many years they've been followed. But again, it's usually very helpful, but not curative. Dr. Ford mentioned briefly focused ultrasound, high-intensity focused ultrasound, kind of like the Gamma Knife. It's focusing many, many beams of ultrasound at a single target. It's integrated into an MRI scanner, and it has sub-millimeter accuracy. So it's being used for tremor, a certain kind of tremor called essential tremor in patients who don't want deep brain stimulation. Some people are just starting to use it for some forms of Parkinson's on only one side when somebody doesn't want deep brain stimulation. But again, it's making a lesion in the brain. So whatever it does, you can't turn it around. One of the great things about deep brain stimulation is if you don't like what it's doing, you just turn the battery off or you reset the settings. So this is, even though it's non-invasive and that we're not opening the head, you're still making a hole in the brain somewhere. But sometimes for epilepsy, that's what we want to do. So people are just starting to apply it to epilepsy, and it's going to keep growing over time in terms of figuring out how to use it. I'm going to show this one other slide here, just shows some of the other areas that we need to improve. So I spent a lot of time talking about stereo EEG versus putting electrodes on the brain. Stereo EEG is still invasive surgery. We're doing an operation where we're putting anywhere from 5 to 20 electrodes in the brain, every one of which has a small risk. So the real holy grail in epilepsy is to find where the seizures are coming from without having to open the brain, even if the MRI is initially normal. So we need to find better ways through brain imaging to detect abnormalities. But because people don't seize all the time, you have to find something. You can't put an epilepsy patient in the MRI scanner and say, sleep there for a week. It just doesn't work. If anyone's ever had an MRI, you'll know. You can't do that. They're loud. No one likes MRI scanners. So you have to find a way to detect seizures in between seizures. So one of the things that happens is even in between seizures, some areas of the brain can have subtle metabolic abnormalities. And so this is one area of research going on where if you look here on the right side, this red bright area has an increased excitatory neurotransmitter in the brain, glutamate, that's being picked up where the seizures are coming from between seizures. So really, we're all waiting for the neuroimaging and engineers and physicists of the world to develop the technology that's going to help put surgeons partially out of business, because as surgeons, we want to be out of business in this area. We want the imaging people to figure out how do we detect seizures without putting anything in the brain. There's a lot of other technological advances that I don't have time to go into, but deep brain stimulation, like Dr. Ford talked about, is now approved for epilepsy in certain targets. He talked about closed loop stimulation, new ways to do that, which is what responsive stimulation is. Using stereo EEG, we can actually make transient lesions in the brain. And actually, over time, people are developing lots of different ways now to actually image the brain. And so this is actually, these are now transparent electrodes that have been developed out of graphene, where you can actually see through them and then record activity in the brain while you're recording a typical sort of EEG. This is animal model work, but it's coming to humans also. So there's lots and lots of exciting things that are coming. So I'm going to finish now. Everyone likes to finish with a feel-good story. This is one of my feel-good stories. This is a patient of mine who was one of our very first patients we ever did stereo EEG on. You know, every patient has to be one of the first in a procedure. She's an extremely high-functioning 35-year-old with multiple graduate degrees who developed seizures in her 20s. We suspect she probably has some subtle developmental thing. We couldn't see it on an MRI scan. We knew her seizures were coming from the right temporal lobe, but unlike those laser patients I showed you earlier, we weren't sure if they were coming from the inside or the outside of the temporal lobe. So here's her PET scan where the temporal lobe itself is abnormal, but again, we weren't sure were the seizures coming from outside or inside. So we decided to talk to her about doing stereo EEG instead of doing a subdural grid. And she was our second patient about 4.5 years ago. And so she had seen many, many people in the US because she was doctor shopping like a lot of people do there. And everybody had told her, you can either take out all of your temporal lobe, which is what surgeons often do in this circumstance, but she's extremely high functioning and she was worried, well, is my brain still going to work the same? Or you could put in electrodes, a subdural electrode through a big operation. So we said, well, why don't we try this littler operation and see if it works? And she listened to it. She had everybody else telling her it was a bad idea. But she said, you know what, it empirically makes sense. We thought it made sense. The Europeans who do this all the time thought it made sense. So rather than in the past doing a big subdural implant or a generous surgery from the start, we did a stereo EEG operation. And in the future, just to include, hopefully we'll have non-invasive ways to actually localize seizures and then ways to treat the brain that don't require actually making a lesion at all. But for her, because it was 2014, we did a stereo EEG implant, put multiple electrodes in the right temporal part of her brain, and fortunately for her and for us, she had a very, very focal seizure onset, just in these few electrodes, which were located right on this inside part of the temporal lobe on the right side. So right in the inside of her hippocampus, just a very subtle area where she probably has a developmental abnormality where the seizures were coming from. So just like in that schematic I showed you in the video before, we did a laser ablation here in her right hippocampus, and she's now seizure-free at 4 years with no neuropsychological changes as a result of that. And most important to her was that she and her husband, they wanted to become parents. And they were struggling because A, she was worried about the risks of the anti-epileptic medications, and then even after she'd been seizure-free, she was still on medicine and she lost a child. And then we just got this card from her a couple months saying, Happy New Year, we want to share with you the news of our son's birth. We're not sure he would be here without you. And it's things like that as doctors that keep all of us trying to advance the field, keep us doing what we do to help our patients, to make things safer, to make them simpler. So in summary, epilepsy surgery is probably changing as much and as rapidly as any field in neurosurgery and in clinical neuroscience. Advanced imaging and these minimally invasive techniques are making it safer for patients, decreasing morbidity and mortality, but like any new technique, we have to see over time, do the benefits last? How well do they hold up for patients? But there's going to be many, many more developments coming because as imaging gets better and electronics get better, we're just going to find better and safer ways to treat the human brain. Thank you.
Thank you, sir, for presenting the technological advances that should be exploited for getting the best outcome in epilepsy surgery. The questions from the audience.
When you do the stereotactic EEG, you provide the laser.
Madam, the mic.
Okay. If you're going to follow with laser, do you just leave that trajectory in and go to the exact same space, or what do you do?
So if we're going to, so most of the time, if we're doing a laser treatment like that case I showed, the stereo EEG electrode comes in from the side of the head with many of them, and then the laser comes from the back at another time. But if we really want to do them together, we can, but there's some technical surgical issues because the screw that we put in for the stereo EEG is a little smaller than the one we need for the laser. So actually we'd have to replace it anyway. Some people have done it. They've gone to an intraoperative MRI scanner and actually, with a robot, taken out one screw, putting in a new one, and then do a laser ablation in the MRI, in the OR at the same time. But usually it's a delay.
But if you want to have a really tiny lesion placed, I mean, how do you know you got the exact same spot? Or you still make a bigger lesion?
You're making a bigger lesion, yeah.
And what's RF ablation?
Radio frequency. So what you can do is, you can actually apply a current. So a stereo EEG electrode may have 14 or 16 contacts. You can pick the individual contacts. If you apply a current down the electrode, it heats it. And the problem is, at least in the US, we don't have a temperature device to tell us how much you're heating it. And in Europe, they have one that's approved. So the device we have, we don't have a temperature approved device yet in the US to do that. Some people are doing it through some other ways, but we're not quite there yet. Not as a community of doctors.
What is the role of anti-epileptic drugs?
So anti-epileptic drugs are always the number one role, right? So if anti-epileptic drugs are working, then there's no reason that anyone should ever be seeing an epilepsy surgeon unless they can't tolerate them. Once in a while, you'll have a young patient who might have a small lesion or an easy type of epilepsy to treat who says, I don't want to be on medication the rest of my life. And for that patient, the best chance of stopping medicine might be surgery. But in general, if medicine is keeping people from seizing, then they don't need surgery.
No, but while during surgery and will they be on drugs?
Yeah. We keep patients, even after surgery, it's very important to stay on your medication for at least 6 to 12 months. To make sure that the brain has plenty of time to quiet down, because if you stop medications too quickly, sometimes that can have negative effects.
Thank you.
What the duration of the procedure? How long it takes?
For which one?
For
SEEG. So as I said, the actual placement of the electrodes takes about an hour, but you have to bring the patient in, put them under anesthesia, get the robot registered, do all the computer work, put the electrodes in, test every electrode to make sure that it's working, do a CAT scan or x-rays to make sure they're where you want them. So all in, it's about 4 hours, but the actual placement time's about an hour, 5 minutes an electrode.
What is the cost of it?
Depends on how many electrodes. Well, first off, the cost of it's going to vary, right? Because the cost of anything, from what I've gathered here, you all do a much better job of containing costs than we do. And in our system, everything's really expensive. So, but you know, an average surgery like this, I wouldn't even know where to start to put the entire budget together, because in the U.S., when you talk about the surgery to put the electrodes in, all the monitoring time in the hospital, you know, if somebody was paying out of pocket, I wouldn't even know where to start, because of the fact that in our system like this, either the government pays or private insurance pays. But these are not inexpensive surgeries, and that's a consideration. Same with the laser fiber. You know, the laser fiber, it's a great treatment, but right now the company's charging, at least in the U.S., you know, over $10,000 for a fiber. And so that's incredibly expensive when you can do an open surgery for under $1,000. So not in our system, but in your system you can. That's what the surgeons tell me. And so if a company is going to charge, they can't. I mean, a company can't come into India and compete with open surgery at $10,000. So they have to understand the market. They have to realize that the market here, the market value is that there are more people, therefore there are more patients. And so, but that's one of the issues with technology, is figuring out what makes sense to pay for.
Is there any contraindication in doing that? Any contraindication for this procedure?
Yeah, I mean, so the most important indication or contraindication is being quite certain about what type of epilepsy you have and where you think it's coming from, right? If you really suspect that somebody has seizures coming, for instance, from several parts of the brain where they have many types of seizures, then to put a lot of electrodes in to confirm that they have seizures from many different parts of the brain doesn't make sense, because we're not going to be able to then do a lot about that anyway. So the most important thing is, how good is your upfront hypothesis as to where the seizures are coming from? And obviously patients have to be healthy enough to undergo surgery. I mean, as Dr. Ford said before, age is not a criterion, health is a criterion.
The reason why I asked that, I'm a cardiologist, and cerebral dysrhythmias, you put electrical radiofrequency ablation for various one. The same thing you are doing for the brain. I think there is a lot of connection between the brain and the heart.
I think you're absolutely right. And that responsive neurostimulator device came directly out of pacemaker technology. And in fact, the cardiologists are way ahead of the brain neurophysiologists in understanding some of their aspects, but also with, you know, I mean, with no disrespect to the heart, I mean, the brain's the brain. And so, you know, I mean, we got a lot more to work through over time. So you got to give us a break. Yeah.
Is there a role for vagus nerve stimulation?
Yeah, so I didn't talk about VNS because it's been around for a while. So vagus nerve stimulation, there's absolutely a role for. What that role is, you'll get different answers from different centers. I mean, vagus nerve stimulation in general, for most types of epilepsy, will give you 50% less seizures in about 40% of people. And so you have to know the patient well. What kind of seizures do they have? And if it would make a significant difference to have 50% less seizures on average, then it makes sense to try. And a lot of times it gets tried before you do something more invasive. You say, because you know what? You don't know. Maybe you'll hit a home run. Maybe you'll be a patient who's got 90% less seizures. And it's much simpler than brain surgery. Putting in a vagus nerve stimulator is a 1-hour operation. You're not doing anything to the brain. So yes, it absolutely has a role. But where vagus nerve stimulation, deep brain stimulation, responsive neurostimulation, the whole stimulation field is wide open. Because A, we have no idea what we're doing, right? I mean, the parameters that we use are the ones, they were picked just because people said, oh, well, let's try that because it worked on a mouse model 20 years ago. Or it just seems to make sense. Or we did it for Parkinson's, right? People, in the human brain, there is so much to be figured out about stimulation and nerve versus brain. So yeah, it definitely is going to have a role though.
Yeah. So thank you, sir, for a nice presentation. Can I request you?
I was just going to do my job.
Oh, excellent.
I think what was really fascinating about this, and actually he addressed a question from Dr. Ford's talk, which is that technology and AI and robotics actually has served a role, but not for the way that we want or think of AI to do, that it's able to provide, time and, time efficiency to have a robot plan something, but it doesn't tell you how to think or how to choose the right treatment. And I think the other point I wanted to bring up, which is, it's just so interesting about how the group of speakers are just going to play off each other, and the next one will do this as well. But that we don't know in any field how to pick the right treatment for a given person. We do the best we can, and we're learning all the time. And I'm just going to, in a prescient sort of way, say psychiatry gets a bad rap, that we don't know how to, pick the treatments for patients and, to make people well. And I think we should all realize that nobody knows how to do it. We just need to keep collecting data to figure it out patient by patient. And I think
I think that's a good point.